Dr. SHEREEN, are you ready to start? Prof, okay. So let's start this session now. Good afternoon, everyone, and welcome to the final rheumatology session of the month, which is on connective tissue disease related interstitial lung diseases by Dr. SHEREEN. And we are extremely privileged today to have with us Professor DATO Dr. WAHINUDDIN to chair our session today. He's a consultant rheumatologist and physician and a clinical professor at the University KL Royal College of Medicine, Perak. So over to you, Prof.
Okay, thank you, Mabel. Thank you, Mabel. Assalamualaikum. Good afternoon. Hello, everyone. Welcome to our webinar. Our topic today is will be on it's a very complex diseases, complex disease, complex condition, which is already well, not to say it's serious, very serious, right? I think lately we heard a lot of things on the from thoracic society, from the pulmonologists, radiologists, even chest physician around this particular topic. But today we are glad. I'm honored to be to have with us Dr. SHEREEN. Is a consultant rheumatologist physician from SULAIMAN Hospital. She's, I think, quite well known to us. It's no stranger to us, I suppose. Dr. SHEREEN. She will be talk on this specifically on what they call this connective tissue disease in relation to interstitial lung disease. As we know, interstitial lung disease, as I mentioned just now, is very serious condition. It's a complication of various what they call this causes and etiology, and the management is a bit complicated. All right. So anyway, without further ado, I pass this to Dr. SHEREEN. Dr. SHEREEN, please.
Thank you, Dr. Wahi, for the kind introduction. I will share my slides first. Okay, thank you to the College of Physicians for this honor. And it's my pleasure today to talk to you all about interstitial lung disease in the connective tissue diseases. So why do we want to talk about the lungs in CTDs? Well, the lungs are actually frequently involved in CTDs, and lung involvement can be a direct consequence of the CTD, or it can occur indirectly. So for example, if you have hypoventilation secondary to a myopathy, or it could be as a complication of the treatments that we use to treat our patients with CTDs. And in addition, since our patients are often immunocompromised, we always have to rule out infections. And this is always the top thing to consider when we evaluate our patients. So the lung can be involved in many ways, and the various parts of the lung that can be affected include the airways, the pleura, the vascular, and the parenchyma. But certain connective tissue diseases are more commonly associated with specific patterns of lung involvement, as shown here in this slide. So interstitial lung disease can occur in all types of CTDs, but is particularly common in systemic sclerosis, rheumatoid arthritis, mixed connective tissue disease, and the inflammatory myopathies. If we look at the prevalence, you will see that there is a very wide variation reported, and as you can see here in this slide. And this is because the prevalence depends on how the patients are selected for the study, and also what diagnostic methods are used to define the ILD. So in systemic sclerosis, if we use HRCT as the way to define ILD, then you will see that about 65% of patients with systemic sclerosis have ILD. If you use pulmonary function tests to define ILD, then the prevalence rises to over 90%. However, we know that clinically significant disease is probably somewhere in much lesser than that. It's probably in about 50% of patients. So how about rheumatoid arthritis? Rheumatoid arthritis is a much more common CTD. It affects about 2% of the population, and it has many extra-articular manifestations, including in the lung, of which ILD is fairly common. But in fact, we don't really know what is the prevalence of ILD in RA because we do not routinely screen for it. In mixed connective tissue disease, so MCTD is a condition where you have overlapping features of systemic sclerosis, rheumatoid arthritis, and myositis. There is also a high prevalence of ILD, especially in patients with systemic sclerosis type features and antibodies, and I'll be talking a little bit more about this later. Conversely, in lupus, in systemic lupus erythematosus, ILD is relatively uncommon. Why is it important to diagnose ILD? So of course, ILD is just one of the many manifestations of lung in a patient with CTD, but it's a very important one because it carries a high risk of morbidity and mortality. So this data is from a study which was conducted utilizing data from the European Scleroderma Registry, the EUSTAR database, and it's a very big registry. It has over 11,000 patients with systemic sclerosis. And they found that the main cause of death, you can see in that first column there, was interstitial lung disease or lung fibrosis at about 16.8%. And the risk was higher in patients with the diffuse subset shown in the red bars. In rheumatoid arthritis, the survival among patients with ILD was also significantly poorer compared to RA patients without ILD, as shown here in this study, which was published in 2010 with over 500 RA patients. So when we're thinking about the presentation of a respiratory disease, it can sometimes occur in, we will suspect it in a patient with a known CTD and then who experiences respiratory symptom that requires further assessment and treatment. But in other patients, it could be the first time the patient presents with any symptom at all. And so it can be the first manifestation of an underlying rheumatic disease. So either way, what we need to do is we need to secure the diagnosis early so that we can intervene early and thereby limit morbidity and mortality. And there are also some times where it could be just an incidental finding. So you may do an imaging or lung function test is done perhaps for some routine, for pre-op screening perhaps, and you find an abnormality. So it's a subclinical finding where the patients could either be asymptomatic or very stable. Or they can present as a chronic progressive disease, or they could even present acutely in a life-threatening manner. So if the patient, we know that the patient has an underlying CTD, then we should know which are the patients that we should screen for ILD, who are at highest risk of getting these lung complications. And we should also know how to screen for it. And in the other patients who present with their lung manifestations as the first manifestation, we should look for clues that will tell us whether or not this patient may actually have an underlying CTD. So this slide, although it's certainly not exhaustive, it does show us some key features that can guide us towards looking for an underlying connective tissue disease. And some features you may not you may miss it if you don't specifically look for it or ask for it. So for example, the presence of Raynaud's phenomenon, which is very common in systemic sclerosis, and also looking at the hands for mechanics hands, which you can see in patients with myositis and the anti-synthetase syndrome. Well, of course, dry eyes and dry mouth is the hallmark of Sjogren's disease. And from imaging, a useful clue is to look for the esophageal dilatation that can be seen in patients with systemic sclerosis, whereas pneumomediastinum may be seen in the myopathies. Now, I would like to share a couple of case histories to better, to make it a little bit more interesting and to better illustrate what I mean. So this first case is of a middle-aged lady, and she presented acutely with respiratory symptoms. She was quite ill. But she then also, on further questioning, gave a history of symmetrical polyarthritis occurring over the last few years. And then investigations revealed high titers of rheumatoid factor and anti-citrullinated peptide antibody. So after infection was ruled out, she was treated as RA-ILD, but she succumbed 2 years later due to complications from infection. So extra-articular disease is common in RA and can occur in up to 50% of patients. And out of this, lung involvement is common, found in up to nearly 70%. But some reports also say that perhaps, the prevalence is a bit lower than that. It's much lower, actually, about 10 to 20%. And this just reflects, what figures we come up with is determined by how the study is done. So sometimes we have to be careful when we interpret what we read in the journals. So why is it important to identify extra-articular manifestations? And we now know that if an RA patient has extra-articular manifestations, they have an increased mortality. And this increased mortality comes mainly from cardiovascular disease, infection, and of course, lung disease. And in fact, it's been found that lung disease alone accounts for up to 20% of deaths, and it's mostly due to interstitial lung disease. Now, in our RA patients, sometimes it can be quite difficult to pick up ILD, and because the symptoms can be quite subtle, and it can be masked because patients have physical limitations. They do not move much because of their joint pain. So early symptoms, so for example, shortness of breath on exertion may not be so obvious. So we, as the treating clinicians, we have to be alert, and we have to have a low threshold to investigate and to refer, especially when the patient reports a new cough, a change in activity level, or low resting oxygen levels. So how do we evaluate? So as part of the evaluation, we should do lung function test, HRCT thorax, and we can also assess resting and post-exercise oxygen saturation. So you can do a 6-minute walk test. And how about chest X-ray? So HRCT is definitely superior over chest X-ray because chest X-ray is very insensitive in picking up changes, especially early changes. And in fact, in a study, they found that if you use HRCT, they picked up about nearly 20% of patients with ILD versus less than 3% from chest X-ray. So you can see it's a very poor test in picking up ILD. So HRCT is recommended for screening because of its superior sensitivity in detecting early changes and also small airway diseases. How about other things like lung biopsy, transbronchial biopsy? So these are usually not indicated in most cases, but it may be helpful to rule out other causes like malignancy or drug-related causes or infection, but it's usually quite low yield. So how about lupus? So in lupus, we have this chronic interstitial pneumonitis, but it's usually mild, it's rarely severe, it's often subclinical actually, and it's usually not a presenting symptom. And very, very rarely, I suppose, it can be progressive and severe, but This is usually more often seen in those patients with overlap. So for example, you may have overlap lupus with systemic sclerosis or overlap lupus with RA. And it's also debatable whether or not there's this entity called acute lupus pneumonitis. And the reason being is because that in almost every case that you think the patient may have an acute pneumonitis, you can also, there are also other confounding factors. You have to rule out, of course, things like infection. The patients may have aspiration or cardiac failure or heart failure or uremia. Because the chest X-ray shows bilateral infiltrates, and this is quite non-specific. And but this condition usually responds well to steroids. Okay, so interstitial lung disease is relatively common in the myopathies. So you have, if you look at the photos here, it's depicting the heliotrope rash and the Gottron's papules of dermatomyositis. And those are the characteristic features of dermatomyositis. So the discovery of the anti-tRNA synthetase autoantibodies was quite a pivotal discovery because it was then linked to the myopathies, and then also it was discovered that these patients who had these antibodies had distinct clinical features, and that led then to the formal recognition of this syndrome called the anti-synthetase syndrome, and I'll show the features in the next slide. But first, let's talk about the antibodies. So there are, in the myopathies, there are two categories of antibodies. You have your myositis-specific antibodies, which are specific to the autoimmune myositis, and they can be present in up to 90% of patients. Whereas in the myositis-associated antibodies, and even though they are present in quite a large number of patients, in up to 50%, they are not disease-specific, so they may also be seen in other autoimmune diseases. So the myositis-specific autoantibodies are closely associated with distinct disease subsets. And this has implications in terms of clinical involvement and the prognosis of patients as well. So for example, the anti-MDA5, which is quite important for us to know because it was first described in Asians, is actually specific to dermatomyositis and also with a myopathic subset, which is a myopathic dermatomyositis. And the other important feature of it is that it is associated with rapidly progressive interstitial lung disease. For the anti-ARS antibodies, the one we are most familiar with is the anti-Jo1, and that is associated with the clinical syndrome, the anti-synthetase syndrome. So in the anti-synthetase syndrome, of course, the main feature is the interstitial lung disease. And in this syndrome, the interstitial lung disease is severe and it's rapidly progressive. And it's usually how the patient presents. It will be the main presentation. But the patient may also have other characteristic features, so like Raynaud's phenomenon, myositis, of course, arthritis, and mechanics hands, and fever. And this condition actually causes significant morbidity and mortality. And usually we need to treat it not just with steroids, but also with immunosuppressives. And the myopathy in some patients may actually even be subclinical. So the main presentation, like I said earlier, is the lung. So the myopathy may not be very obvious, or it may be even present later on in the course of the disease. So a good take-home message is that in someone who presents with an acute fulminant respiratory problem, like for example, an ARDS, so do look at the patient's hands, especially if there are other suggestive symptoms, and look for things like the mechanics hands and Raynaud's, and then send for the anti-synthetase antibody and of course the muscle enzyme levels. And you need to have a high index of suspicion so to diagnose this condition. Okay, now we move on to the next case history. So for this, I need to thank one of our trainees, Lydia, for sharing her slides with me. So this next case history is of a 60-year-old lady who had a history of working with pesticides since she owns an oil palm plantation. And she presented with a 2-year history of skin tightening with changes over her facial features, actually noticed more by her neighbors rather than herself. And these changes was also associated with increased pigmentation and areas of depigmentation over the face, shoulders, and limbs. And she also had difficulty opening her mouth. And these areas of the skin was also quite itchy. However, she didn't seek any medical attention until her condition worsened over the past 6 months, and everything worsened. So the skin became tighter, she started to have constitutional symptoms, and then she began to have reduced effort tolerance. And at this stage, she also had other symptoms, including joint pain and Raynaud's phenomenon. And she was actually seen at several GP clinics and healthcare clinics before someone finally referred her to dermatology, who then subsequently referred her on to us. So you can appreciate from these photos what I described earlier. So you can see she's quite dark. I think she wasn't as dark before. So she says that this is definitely darker than what she used to be. And those areas of depigmentation is quite typical of patients with systemic sclerosis. And we call it the salt and pepper appearance over the skin. And when we measured the skin scores, she had a modified Rodnan skin score of 29. I'll talk a bit more about this in my next slide. So in the picture of the hands, might be a bit difficult to see here, but we thought that she had sclerodactyly. She did not have any digital ulcers, but the hands overall looked a little bit puffy as well. And that is also a feature that we see with patients with systemic sclerosis. So the modified Rodnan skin score is a reproducible, semi-quantitative measure of skin thickness, and we measure it at 17 sites over the body. And a higher skin score does predict internal organ involvement and also predicts mortality. And we also performed a nail fold video capillaroscopy, and this showed an active pattern. So nail fold video capillaroscopy is a useful tool that we use to differentiate between primary and secondary Raynaud's, so secondary due to CDD. And in systemic sclerosis, there is a typical pattern, and the typical pattern correlates with disease severity and the extent of organ involvement. Okay, so she could not complete the 6-minute walk test because she was breathless. The lung function test indicated that she had restrictive disease, and then blood tests revealed a positive ANA with a positive anti-SDL70, which is consistent with diffuse systemic sclerosis. So and then a HRCT was performed, and this showed the presence of interstitial lung disease with features more suggestive of hypersensitivity pneumonitis, but with also a differential diagnosis of ILD with an NSIP pattern. And I'll talk a little bit more about these patterns later. So we discussed this case at our multidisciplinary meeting, and I'd like to introduce that concept here. So we have actually been having radiology conferences with the radiologist over the years, but last year was the first time we actually started this meeting, and we found this so very, very useful. And because of the pandemic, of course, it's all done virtually, which is actually even better because we can then bring together everyone, even from various centers. So we had the respiratory physician with a special interest in ILD joining in from IPR, Dr. SHEREEN. And then we also have our thorax radiologist from UITM. And Dr. Muhammad actually left for private. But then he's still continuing to join us in this meeting. So it's a very useful sharing session. And it's a session where we actually discuss the cases and then we come to a consensus about what the pattern of ILD, or first of all, whether the patient has ILD, and then the pattern of the ILD. And then we also come to an agreement about what is the next course of action for the patient, whether further investigations is required and what sort of treatment. So that is what was done for this patient. So the conclusion was that she has CDD ILD, but there was also a possibility of pulmonary hypertension. I won't go into details here because we don't have time for that. But we do suspect pulmonary hypertension in patients where there is a high FVC to DLCO ratio of more than 1.4. So now that I've given you some idea of how CDD-ILD may present, let's go a little deeper into the topic, starting with the pathophysiology of it. So the underlying pathology in CDD-ILD is dominated by inflammation and fibrosis, or a combination of both, with a distinct radiological and histopathological patterns. And I will talk a bit more about that later. So inflammation and fibrosis can coexist, especially at the early stages. And the pathogenesis involves multiple cell types, and there is interplay between various cellular components, including the endothelial, epithelial, interstitial, as well as the innate and the adaptive immune system. And they all interact together with the extracellular matrix and with each other. And the ultimate ending of this process is fibrosis. Okay, so next we move on to the classification of CDD-ILD. The currently used classification is based on the histological classification used for the idiopathic interstitial pneumonias. So, and all the patterns seen in the IIP are also reported to occur in CDD-ILD, but there are differences in terms of the prevalence and the prognosis between those seen in the CDD-ILD versus those in the idiopathic ILD. So you can see from this table here, in idiopathic ILD, the usual interstitial pneumonia pattern is the most prevalent pattern. And by contrast, in CDD-ILD, NSIP, non-specific interstitial pneumonia pattern is the most prevalent pattern. So then you might then ask yourself or think to yourself, is this important? Is it important to distinguish, to make a distinction between a UIP and an NSIP pattern? Does it carry any prognostic significance? So in systemic sclerosis ILD, we are still not sure, but in RA ILD, there are studies that suggest that patients with the UIP pattern may have a worse prognosis than those who have an NSIP pattern. But again, you know, this is not black and white, because this has also been disputed in other studies as well. But nonetheless, it's thought that it's still important for us to classify patients based on the pattern of ILD. And how do we do this? So this is now done mainly through HRCT, and we extrapolate this from idiopathic disease, where they found that a HRCT pattern, which is typical of UIP, is virtually pathognomonic of UIP at biopsy. How about in the CDD-ILD? So we don't have as much data. Data is limited, but I'm showing here you here a small study done with 60 patients with RA ILD, where HRCT appearance of definite UIP had a specificity of 96% versus findings from a surgical biopsy, and that's pretty good in my book. So nowadays, biopsies, we generally just restrict it to the minority of patients who have very atypical features or clinically or on HRCT, or especially when you need to rule out conditions like malignancy. Now, very quickly, I would just like to bring up this group of patients which are classified as idiopathic pneumonia with autoimmune features, or commonly called IPAF. So these are a subset of patients where they have ILD, but the clinical features of CDD may be subtle. It could be they just have a bit of joint pain, you know, maybe very subtle, or maybe even none at all. But then in this group of patients, they may have positive antibodies. So in this group, the immunologic tests have an important role in the detection of an underlying CTD. So they do not actually fulfill the criteria, the classification criteria for CTD, but they may have maybe one or two features and they have the antibodies present. So the major autoantibodies and their associated CTDs are shown in this table. And why is it important? Why do the respiratory physicians want to pick out this group of patients versus the rest of their idiopathic patients? And that is because there are implications in terms of prognosis and how we manage these patients. So there is this proposed algorithm, and I'm sorry, it looks a little bit blur here, that recommends what tests that you should do first, and then following that, further on you may want to do some other test. But what we need to remember is that actually this kind of algorithm, we are not sure how much value it gives us diagnostically, and especially the cost effectiveness. But it's a useful way, and I think more and more respiratory physicians are using this kind of algorithms, especially when it's not very clear that the patient has an underlying CTD, to pick up the group of patients who may have an underlying CTD. Now let's take a closer look at systemic sclerosis ILD, because it's definitely the most widely researched among all the CTD ILDs. ILD is a frequent complication of systemic sclerosis. And if you remember, I showed you earlier data from the European Scleroderma registry, and it showed that ILD is a leading cause of mortality in systemic sclerosis. And although up to 90% of patients will have ILD, and this is based on HRCT, about 40% of them will have a restrictive lung disease when you measure them using the pulmonary function test. And out of that, around 50% will have severe disease, so which is defined as a forced vital capacity of less than 50%. Because why is it important? Because we know that those with a very low FVC will have higher mortality, and that is seen in around 10 to 15% of patients. And one thing I must say before I forget to bring it up is that ILD is not just seen in diffuse, it can also be seen in patients with limited systemic sclerosis. So then you may ask, is there any way that we can predict which systemic sclerosis patient is likely to get an ILD? And of course, from the studies, there are several parameters that have been identified to be associated with ILD, including being male, having an African American descent or ethnicity, higher, like I mentioned earlier, higher modified Rodnan skin score, presence of cardiac involvement, serum CK levels, anti-topoisomerase antibody present, and the absence of anti-intermediate antibody. And more recently, there are reports of this anti-U11U12 RMP antibody, which is a new serological marker of the systemic sclerosis ILD. But although studies show that these are the factors that identify patients who are at higher risk for developing systemic sclerosis ILD, we must remember there are no demographic, clinical, or immunological features that allow definite prediction of ILD in an individual patient. Because the other reason is that symptoms are not very helpful, because our systemic sclerosis patients, they have many other issues. So just like the same in RA, they may have joint symptoms. And then the skin changes and they are usually very fatigued. And all these will just reduce their physical function and then mask the symptoms of breathlessness and all that. And I think our patients are also very good at adapting. They just like live with it, and then they don't think that it's an important symptom to report. And of course, so all these contribute to ILD being not recognized and causing a delay in diagnosis. And then of course, our systemic sclerosis patients also have other complications such as pulmonary hypertension or also cardiac disease due to myocardial fibrosis. And all these might lead to systemic sclerosis ILD being overlooked. So this brings me to a very important point, which is that all systemic sclerosis patients should be regularly screened for systemic sclerosis ILD. And besides patients with systemic sclerosis, the other group of patients that should undergo routine screening are those with mixed connective tissue disease or other connective tissue diseases like lupus, with prominent scleroderma features. And we call this the scleroderma spectrum disorders. So these are the patients who have very prominent Raynaud's, there are nail fold capillary changes, and also they may have actually scleroderma specific antibodies. Okay, how are you guys doing? Now let's move on to the management of CTD-ILD. So these, we very recently, we had it was published in the Lancet Rheumatology, the consensus statements for screening, diagnosis, and management of systemic sclerosis ILD. And very helpfully, these consensus statements were summarized into this clinical algorithm for clinical practice, as shown in this slide. And this algorithm highlights that all patients with systemic sclerosis ILD should undergo screening for ILD using HRCT. And it's not using chest X-ray, it's using HRCT. So HRCT has a very important role here. And it's not just for diagnosis, but we also need it to assess the severity of disease. And because it can tell us, what is the extent, what is the pattern, and whether there are already any complications like reduced lung volume or bronchiectasis. So the other tests, or the lung function tests, the FVC and DLCO specifically, and also symptoms are also used. And this can also help us to decide the severity at the baseline, and especially at follow-up for monitoring, the lung function test is very useful. So for patients with evidence of disease progression, or those with inadequate response to treatment, then we should consider for treatment escalation. So other than for systemic sclerosis ILD, actually there are very limited data. There's no clinical trial data. I mean, we may have case reports, observational studies, but no controlled clinical trial data. And so sometimes it can be quite difficult. And usually we would perhaps just extrapolate using data from systemic sclerosis ILD. And the other challenge is that the available therapeutic options are actually not that many. And also because our CTD diseases, they are so heterogeneous. And so sometimes, we wonder, is it okay to extrapolate the data? So these are all the challenges when it comes to treatment. But the other important concept to remember is that not all patients with CTD-ILD need treatment. And whenever we want to decide whether or not to treat a patient, so that's why you see the MDT meeting is so helpful, because we are all discussing, looking in terms of the clinical aspect, as well as the radiological aspect and the physiological aspect, the function, the lung function. So all these will help us to make a decision, and of course, weighing that against patient's age, comorbidities, and we have to take all this into consideration when we are deciding whether to treat a patient. And all patients need supportive therapy, and for certain patients, perhaps those who are very, functional class 4 with very bad involvement, assessment towards lung transplantation would also be required. So then, and then of course, those who are end stage, we would also need to refer the patients on to the palliative care. So in terms of pharmacotherapy, the cornerstone of pharmacotherapy for our CTD-ILD patient is immunosuppressive therapy. And some patients will be treated with immunosuppression anyway, because it's needed to treat the other systemic manifestations of their disease. Steroids is commonly used as the initial treatment option, and it's quite useful, especially in certain forms of CTD-ILD, for example, organizing pneumonia. Although actually, if you look at the literature, there is very little evidence. And in the other condition where it's very useful is in acute fulminant inflammatory, idiopathic inflammatory myopathy associated ILD. in which high-dose steroids is definitely beneficial. But in systemic sclerosis ILD, we have to be careful when using steroids, and especially in patients with diffuse disease, and we generally use prednisolone 10 milligrams daily or less. And this is because higher doses have been associated with renal crisis in patients with early disease, especially early diffuse disease. And also, actually, there is really not much evidence to prove the efficacy of steroids in systemic sclerosis ILD. So in terms of immunosuppression, the cyclophosphamide this was the pivotal, we call it the pivotal systemic sclerosis ILD study, because the SLS1, the Scleroderma Lung Study 1, was the first large randomized placebo-controlled clinical trial designed specifically to investigate systemic sclerosis ILD. So in this study, patients with active symptomatic disease were given 1 year of oral cyclophosphamide. And the results showed, it's small, but it was a significant treatment effect on the forced vital capacity, dyspnea score, and skin thickness. Then this SLS2, before that. So when they evaluated 1 year after, so the patients were treated with oral cyclophosphamide for 1 year, and then they were discontinued. But the patients were continued under follow-up. And when they evaluated 1 year after stopping treatment, they found that the benefit was maintained at 18 months, and then it waned to placebo levels. So then next we have the SLS2 study, and this one assessed MMF, which was given for 2 years versus 1 year of oral cyclophosphamide. And the primary endpoint was the change in the forced vital capacity at 2 years, which if you look there, it's quite similar between the MMF arm and the cyclophosphamide arm. So there was no difference in terms of efficacy between the two arms, but what was significant was that MMF was better tolerated than the oral cyclophosphamide. So then the other major trial for systemic sclerosis ILD is this trial called the SENSIS trial, which studied the safety and efficacy of nintedanib, which is an antifibrotic in systemic sclerosis patients. And this was a very, very large study, and with about 20% Asian patients. So you can see here from this table the disease characteristics. I won't go into much detail because I think we are running out of time. But what I would like to point out here is that so they had half patients with diffuse and half patients with limited systemic sclerosis. And the other thing was that the HRCT extent was about 36%, and the mean FVC was 72%, the mean DLCO was about 52%. And approximately 60% of them had anti-topoisomerase antibody positive, and almost half were taking mycophenolate at baseline, and background treatment with prednisolone or mycophenolate or methotrexate was allowed. So the primary endpoint of this study was the annual rate of decline in FVC assessed over 1 year. And they found that it was significantly lower in the nintedanib group compared to the placebo group. And this is, remember, the annual rate of decline. So the relative reduction was about 44%. And this reduction of the rate of decline happened regardless or not of whether the patient was on mycophenolate. So on the basis of this trial, nintedanib is now approved for the treatment of systemic sclerosis ILD. So there are also other therapies which have been studied, and these are rituximab and tocilizumab. So I don't think we have time to go into that. So very quickly before I end, I would like to share our experience of setting up the combined respiratory clinic at the rheumatology unit at Hospital Selayang, or more specifically, it's actually a cardiorespiratory screening clinic, which was established in 2013. So the main purpose of this clinic is to screen for cardiorespiratory complications in patients with scleroderma and the scleroderma spectrum disorders. And the procedures that are done spirometry, transthoracic echo, 6-minute walk test, the nail fold video capillaroscopy, and except for HRCT and full lung function test if required, all the other procedures are done on site at the same time within the same clinic setting. And then the patients would then be reviewed by both the rheumatology and the respiratory teams. And at the first visit, all patients would undergo spirometry, and if required, they would then be referred on to either UITM or IPR for the full lung function test. And if the results indicate a restrictive pattern, which is actually most of the time, then a HRCT will be ordered. If the patients are stable or normal, then we will schedule a repeat screen in 1 year, especially for patients with early disease. But if the patients have symptoms, or if they have ILD, then of course we will see them earlier with further investigations as required. And all this, of course, requires multidisciplinary involvement, and we have been very fortunate to have good collaboration with our respiratory colleagues from UITM. So you can see the respiratory team here on the left, and on the right is Dr. Habibah and Dr. Noliza from our rheumatology unit at Hospital Selayang. And then in this photo here, we have our nurse in the middle there, and she helps to coordinate all she coordinates everything so that everything is done smoothly. And then at the bottom photo, you can see Dr. Avrina, one of our trainees, doing the nail fold video capillaroscopy and the 6-minute walk test, which is now done by the staff from UITM, and we're very grateful for help from them. So yes, so we started off with an initial cohort of just over 40 patients, but now we have screened over 100 patients, and we have managed to present our results in several meetings and conferences. So with that, I would now like to end my talk, and I hope I've given you an overview of CTD-ILD. And I must say before I end that this is an evolving field. So do watch out, for new developments, and thank you for your attention.
Thank you, Dr. Shereen, for the very informative talk on ILD in relation to connective tissue disease. Now we open the floor for question and answer. The participant can write their, ribbon down the Q&A. Please do write the question on that, and then I will read it for you. Or how, Mabel? No question yet.
I hope I haven't put everyone to sleep.
Yeah, that's hi, Dr.
That's Dr. Mariam. She's one of our trainees.
All right. Any question, Dr. Mariam? Yeah, I just want to probably start the ball rolling. Shereen, what actually the limitation of a HRCT in diagnosing of what you call this interstitial lung disease?
Actually, HRCT is, like I said, very, very useful. And the only limitation, I guess, is the accessibility to it. Like we cannot get it immediately. So you have to wait. You have to get the appointment. And also, it needs to be interpreted carefully. So in the past, we often would get reports, like very non-helpful reports, like just maybe they would say lung fibrosis, and they do not actually give us the pattern. So it's very important not just to do the HRCT, but to have it interpreted by someone who's been trained to interpret the HRCT. So that's why having the MDT meeting with the thorax radiologist is very important. And so for those centers who don't have a thorax radiologist, I encourage you to join in to our MDT meeting. So we have it at Selayang. Now IPR does it regularly, and now IPR is also doing it with HTAR and also with Prof. Maleha in Sabah. So we can just, if we have any patient that we are not very confident of the diagnosis, we can just bring it up to the MDT. Yeah, because you need the people who are trained to read it.
Yes, agreed. I mean, certain centers, there are limited resources for this. I'm facing the same problem because we just based on basically on clinical diagnosis that we have to discuss. Okay, we have a chest physician around, we have a radiologist, but we have to emphasize to them, please give a definite report, according to whatever you mentioned just now. Definitely, what is it ILD, is it UIP or an SRIP, etc., etc. So it helpful, but other like spirometry full lung function test is not available in especially in certain private center. There's a big problem. So we just give based on really strong clinical judgment on that. I had my own experience treating such cases, MDA5 related rapid RP-ILD. She's survived. CHAIRPERSON. She survived. Now with a combination of all this immunosuppression.
Yeah.
So okay. There's a question from Dr. Mariam. Which would you choose between IV CYC or MMF mycophenolate for scleroderma systemic sclerosis ILD? If IV CYC cyclophosphamide, which regime would you prefer?
Yeah, so thanks, Dr. Mariam, for the question. So we know from the SLS2 study that there is no difference in terms of efficacy between cyclophosphamide and mycophenolate. But the difference is actually in terms of the safety profile. So of course, we know MMF is better tolerated, it's friendlier towards female patients who are still in the childbearing age. So of course, actually, internationally, the recommendation would be to go for MMF first. But we do sometimes, even in our center, we do choose cyclophosphamide, and we normally prefer to use IV rather than oral. And that's because because we are familiar with using IV cyclophosphamide. We use it to treat our lupus patients and all that. So we are familiar. And which regime? So Mariam, you would know this. In SULAIMAN, even though it's not it's not been done in any formal study, we still use our Eurolupus regime because we find that it works and it's very well tolerated. So of course, in the FAST study where they use IV cyclophosphamide, it's a little bit different. So it's based according to the weight of the patient. So you can also choose that regime, but I personally find that using our good old Eurolupus regime is good. It works and it's well tolerated.
Great. Thank you, Dr. SHEREEN. Your pulse IV cycle, for how many cycles that you use?
So we usually assess the patient after 3 months.
3 months.
So we would assess them again using the spirometry at least. Of course, a full lung function test would be better, but at least just the spirometry looking at the FVC. And if they respond, then we would continue. Generally, we would continue on for another 3 months. So this will be for IV cyclo. And then, depending on case-to-case basis, we would either switch them to azathioprine, or if we feel that you need to continue on, perhaps the patient is responding but not responding as well, then we sometimes do switch them to mycophenolate.
I see.
Yeah. But of course, in some patients, we do straight away give them mycophenolate, but I think in some patients, I don't know, sometimes, it's compliance issue and things like that.
Right.
And some patients' preference also, actually, some patients actually do prefer to come in. You'll be surprised, they do prefer to come in for IV treatment.
Do you advocate the use of cyclosporine, then the tacrolimus as well?
So the other second-line treatments, like I said, actually there's no evidence. There's no, it's all, I suppose, on our personal experience. Those, I suppose, would be reserved for cases which are refractory, I think, to the first-line, second-line treatment. But then now with the antifibrotics coming into play, I think there's a bit more that we can play around with. So if cyclophosphamide or mycophenolate either doesn't work, then we have the option of combination therapy as well.
Any more questions from the participant? I think Dr. SHEREEN is become waiting anxiously.
Oh, that's okay. If everyone wants to go and have a cup of tea now, that's okay.
Not yet, another 5 minutes. How fast you treat? The earliest possible. If patient, let's say, at the onset, they found this, what do you call this, ground glass opacity.
Prof, there's 2 questions at the Q&A box.
Okay,
yes, I see them now.
Where's the question? what is your experience using tocilizumab? Yes.
Tocilizumab is actually now, yes, and there are studies looking at tocilizumab in ILD, especially systemic sclerosis ILD. Actually, I personally, I've not treated anyone with tocilizumab for systemic sclerosis ILD, but I have so I know, like, I think Prof. Jasmine in she has experience using that. And so I think, yes, again, for patients who do not respond to the first line treatment, and you think that, so of course, there's no actual data yet to guide us, but I suppose if you think the patient still has a predominantly inflammatory component towards their ILD rather than a fibrotic component. So in NSIP, you can have an inflammatory NSIP or a fibrotic NSIP. So if you think the inflammatory component is still very prominent, then it's worthwhile trying another immunosuppressive agent, perhaps with or without the antifibrotic. Whereas if the patient has more of a fibrotic pattern, then maybe that might steer you more towards using the antifibrotic. I mean, I don't know 100% whether this is correct. I think this is all still, even the experts also haven't come up fully with a guideline yet, because it's still all quite new.
Okay, there's another question. What are the indications to start treatment or treat aggressively for CTD ILD?
So yes, so like I mentioned in the talk, that you may find many patients with ILD, and some of them can be very stable and they do not actually even progress at all. So we have patients under our follow-up and their FBC is not that great, but they remain the same and they have no symptoms, so we don't actually treat them. So how do you decide when to treat? So that's where the HRCT comes into play. So like if you remember the algorithm, you look at the extent of the HRCT. So if the HRCT involvement is more than 20%, and also the type of the pattern. So if there is definitely a big involvement, so more than 20% involvement, and especially if the patient has a low FVC and with or without symptoms, then of course that would prompt you to start treatment. And then of course, between those that you monitor at baseline, and they may start off with quite normal FVC perhaps, even though they may have some HRCT findings. So maybe not so bad, maybe between 5 to 10%. Monitor them when they come for their regular checkups and regular screening, you find that their FVC is deteriorating. And these are the patients that we would also start treatment as well. And of course, at any time if they're symptomatic.
Okay, thank you, Dr. Shereen. Any more questions? I think you have 1 or 2 minutes. Yeah, otherwise you can wrap up the meeting.
There's one more question. I think it just came up.
Oh yeah. Wait, let me see. Is there a way I could differentiate inflammation and fibrosis?
Of course, the ultimate way is to do a biopsy, but like I mentioned, biopsy is usually quite invasive, and we normally only reserve it for cases when after we do the MDT, we are still not quite sure what's going on. So actually, the thorax radiologists are very good at picking up. So like I said earlier, they can differentiate between the fibrotic and the inflammatory type, from the HRCT. And of course, you can also look at your acute phase reactants, your ESR, CRP, yes.
Okay, any more questions? If no more, I think, we should, I think, you can end of the seminar. I would like to thank Dr. Shereen for very informative and detailed in ILD. I learned something today. Thank you, Dr. Shereen. And of course, thank you for Academy of Medicine for giving us the rheumatology the opportunity to present today. And of course, all the participants who are listening to Dr. Shereen's lecture today. Then hopefully, we have a lot of gain a lot of knowledge today. Thank you again, Dr. Shereen, and hopefully we see you again. Okay, member, pass it to you.
Okay, thank you, Prof. Thank you, Dr. Shereen. So we will end our session for today. Next month will be on dermatology. So stay tuned, everyone. The poster is going to be released soon. We'll be sharing our QR code for this session. All right, thank you, everyone. Bye.
Thank you. Bye.
Bye.
Afiq. Afiq.
Ya, saya.
Afiq, sorry kalau nanti nak message you how your phone will start.
Boleh, tak apa, nanti saya contact doktor.
You
Saya
contact
pakai
me, ha?
nombor lagi satu ni.
Alright, bye.
Alright.
Thank you, Afiq. Bye.
Thank you, doktor.